Thank you very much, Dr. Prashant, for your kind introduction, and thank you to the Providence team for asking me to speak. I think in terms of looking and understanding diabetic dysglycemia, postprandial hyperglycemia has kind of resurrected itself as and reappeared as a new kid on the block. And I'm very pleased to be looking at the evidence base for postprandial hyperglycemia and whether we should treat that to target. So the first thing to actually understand is that postprandial spikes are in glucose are actually part of the normal physiological process, but they rarely go above 140 milligrams per deciliter in a non-diabetic situation. And what we're really concerned about in this is why they spike above that, what might be the importance of understanding the relevance of this. And to make it very focused, I have a series of questions that I'm going to be answering. So the first question is, why do people with diabetes have postprandial spikes in glucose? And the answer, part of the answer, which we all know is, especially in the Indian context, is the very high carbohydrate content in our meals, 60 to 70% as compared to probably about 40% in a Caucasian diet. But clearly, this is not the entire story. If you look at the pathophysiology, really, it's the loss of the early phase of the spike of the insulin, in the early release of insulin in response to a glucose challenge. We need to recognize that diabetes is a bihormonal disease, and there's also the excess production and the non-suppression of plasma glucagon. What this does is that there is increased production of glucose from the liver. This is something that we need to understand because it's not just about the food that we eat. And all of this leads to a spike in the plasma glucose. So there are multiple physiologies involved, primarily three. One is obviously your meal size and what you're eating. Secondly, it's the endogenous glucose production, primarily from the liver. And the third one is obviously what is being done with that glucose in terms of the disposal in the peripheral tissues. So one of the key concepts is that hepatic glucose production also accounts for a significant part of postprandial hyperglycemia in type 2 diabetes. You can look at the slide on the right, which says that it's about 28% is the contribution of that in terms of the postprandial glycemic spikes in type 2 diabetes. Why is this important? Because it's important to recognize that postprandial glycemia, hyperglycemia results from the loss of the early insulin release in type 2 diabetes. Also, that early initiation of insulin actually suppresses the hepatic glucose production, and that can limit postprandial glucose excursions in type 2 diabetes. And also, this allows us to understand the relevance of other hormones that might be used in actually suppressing the glucagon production, which might help to deal with postprandial glycemia. Second question, do these spikes actually matter? So we know that we've always focused on fasting glucose and HbA1cs, but almost 40% of patients who have a good HbA1c, in inverted commas, might have significant glucose variability, might have postprandial spikes. We understand that if you want to really get a good HbA1c, you need to focus on both fasting plasma glucose and postprandial glucose. I will not go through this slide in any detail. I'm sure all of you are aware of it. So having understood that these spikes do matter in terms of our gold standard HbA1c, do these spikes have any independent deleterious effects independent of a suboptimal HbA1c? So this is the key question, really. Is there any difference other than understanding how they impact HbA1c? And the best study for this, or one of the very good studies in this, is the DECODE study published in the Lancet, which essentially showed, in summary, that you can see here, that irrespective of whatever your fasting plasma glucose is, if your 2-hour postprandial glucose is on the higher side, then that increases your relative risk of death. So you can see here on the extreme left, even if your fasting plasma glucose is less than 110, as your postprandials begin to rise, you actually have a higher risk of dying. If you look at what happens to people after a myocardial infarction, one of the significant factors that has a good predictive value of a subsequent myocardial event or a subsequent MACE is actually the glycemic excursions of that particular patient to greater than 70 milligrams per deciliter, high and low. It's not actually your HbA1c. So glycemic excursions do matter. And if you look at this study, which looked at elderly people who had already had an MI, and pursued one arm with a prandial insulin strategy and one arm with a basal insulin strategy, they found that it was better in terms of in preventing a subsequent myocardial event if you followed a prandial insulin strategy, focusing on postprandial glucose. So PPGs are important. And this is actually a very good epidemiological study, which is looking at a 33-year survival rate based on a 2-hour 50-gram GTT, essentially showing that, as there is a continuum of risk that rises above 83 milligrams of deciliter 2 hours post-glucose load. You can actually predict what is going to happen to these people 10 years, 20 years, 30 years down the line based on what they do after a 50-gram glucose challenge. Clearly, that is important irrespective of your HbA1c, or gives us something more than just an HbA1c. The next question is, what value do you then target? Do you want to look at a 2-hour value, or do you want to look at a 1-hour value? There's evidence for from Cavalot et al., who published essentially telling us that 2-hour postprandial glucose is a very strong predictor of cardiovascular events compared to fasting plasma glucose. So we had some evidence that 2-hour PPG has some independent predictive value. And we have some recent evidence saying that actually the 1-hour postprandial glucose might be even more significant in predicting oxidative stress, in predicting endothelial dysfunction and other things. So there's a question that we really need to answer, which is there a need for a paradigm shift in terms of what PPGs we are focusing on? We've always focused on 1-hour PPGs when we look at gestational diabetes, but outwith of that, we've always looked at the 2-hour role. Trying to clarify this even further, the Israelis did a 33-year follow-up looking at the clinical implications of 1-hour postprandial glucose control. And I don't have time to go through all of it, but essentially, in a nutshell, if you look at the second slide, which is the second part of it, second line, which is B, even if your 2-hour postprandial glucose was less than 140, your mortality was higher if your 1-hour postprandial glucose was above 155. So a 1-hour PPG of greater than 155 predicts a 28% increased risk even when the 2-hour postprandial glucose is below the gold standard of 140. So 2-hour PPG may not be the entire story, and it's watch this space as we look at it. Okay, so now that we know that we need to look at this, how do we actually capture it? How do we actually really look at it? And the whole concept of time in range, again, for brevity, I will not go into it, but continuous glucose monitoring has given us an entirely different picture of how to look at dysglycemia, and obviously looking at postprandial spikes is part of it. There's also the glycomark test, which is FDA approved, used widely in the US, and you might see it here in India as well, which looks at 1,5-anhydroglucitol, which is a very good marker of a postprandial spikes over a 2-week period, and with a marker of less than 10, suggesting high postprandial sugars even in those with HbA1c of less than of 7% or less. You can just see here, you can see the second person who's is a 49-year-old male with an HbA1c of 7.2%. You might pass that as a very good control, but if you look at his 1,5-anhydroglucitol, it's less than 10, it's 4.5, which actually says that over the last 2 weeks, this chap has been having significant postprandial excursion. So it's a very good marker and adjunct that you can use along with HbA1c, something that you might see here in the near future. Therapeutics, how do you want to, now that you've understood that it's important, how it relates to mortality, we think we know how we can measure it, how do we actually do something about it? Obviously, especially for type 1 diabetes, carbohydrate counting, carbohydrate control, understanding your portion size, understanding the diet, glycemic index, correlation with lipids, a high fat meal, etc. All this is very important. If you look at oral agents, you have the meglitinides like repaglinide, natiglinide, which are traditionally being used to deal with postprandial spikes. You have alpha glucosidase inhibitors, both acarbose and voglibose. And if we understand the physiology of the high hepatic glucose production, then you can understand why DPP-4 inhibitors and injectable GLP-1 agents, especially the shorter acting injectable GLP-1s like lixisenatide, etc., might have a big role to play in terms of managing postprandial spikes. if you look at what is new in terms of insulin, we've always been trying to shift the curve to the left in terms of trying to mimic normal physiology. So from regular insulin to rapid acting insulin, trying to mimic what the normal pancreas does. And we now have ultra fast acting insulins, again, trying to deal with this. If you look at the previous kits that were on the block, there's data from pharmacokinetic and pharmacodynamic studies that probably glulysin, which is the only zinc-free insulin of the previous lot, had faster onset of action. Whether that actually translates into clinically meaningful outcomes, we don't have data for that. There's also a trial which has looked at glulysin versus aspart in obese type 2 diabetes, showing that glulysin has a better control of postprandial spikes at 1 hour. Although over the entire period of that study, if you looked at the 6-hour window, there was no particular difference. So if you think that 1 hour postprandial glucose is important, then you might want to take a closer look at this study. Obviously, aspart has been catching up with the faster acting aspart, which is an ultra fast acting insulin with niacinamide in it, which actually makes it easier for it to form monomers and quicker absorption into the bloodstream, essentially trying to target the postprandial spike, essentially within the first 1 hour. If you look at the graph for this, you can see here that if regular aspart is at 21 minutes, then fast acting aspart is at about 16 minutes. So it's twice as fast in terms of appearance in the bloodstream, and probably a 74% greater glucose lowering effect within the first 30 minutes. Again, this makes sense if you think that the 1 hour postprandial glucose is something to be targeted. So that's why I presented the evidence for that as well. And if you look at what evidence faster acting aspart has, in type 1 diabetes, it certainly gives superior 1 hour and 2 hour postprandial controls versus insulin aspart. And in type 2 diabetes, the 2 hour values were non-significant, but at 1 hour, it has better postprandial control. So all of this is in terms of what we can do to target postprandial spikes. So let me summarize by saying that the relative contribution of postprandial glycemia to overall HbA1c is significant. We all recognize this. PPG is probably an independent predictor of cardiovascular risk, as we know from the DECODE study and the various other post-myocardial studies that I presented, and also the epidemiological study of the 33-year follow-up, etc. There's some evidence that actually 2 hour PPG may not be the whole story, and high glycemic spikes at 1 hour may be even more significant in terms of the oxidative stress, in terms of endothelial dysfunction, damage, etc. There's also some data about carotid intimal thickening and carotid and coronary artery thickening, etc., which for paucity of time I did not present. And newer therapeutic molecules like faster acting insulins, in addition to the basics of carbohydrate counting and our oral hypoglycemic agents, which we've always used, can help in treating PPG to target. Thank you very much.